Good morning, colleagues, and welcome to the session. My name is Mopo Khadebe, and yes, I think now we'll get started. We are 6 minutes over time, so yes, welcome to our fifth and final regional think tank session on improving the quality of PrEP implementation for adolescent girls and young women. We are very excited that you could join us for today's session, which focuses on measuring and monitoring the effective use of PrEP. As indicated earlier, for those who may have missed it, my name is Mopo Khadebe. I'm from WHO South Africa. So to get us started, I would like to take you through the session aims and objectives. So the aims and objectives of our session of the think tank outlined below. The aim of the regional think tank and webinar series is to inform quality implementation and scale up of PrEP programming for adolescent girls and young women in the East and Southern African region as part of combination HIV prevention interventions. So below our objectives, to engage and convene diverse stakeholders as we have done, generate implementation considerations, document and disseminate key considerations, and share best practice, evidence, and lessons learned from implementation. Please note that we do have a Delphi survey for consensus. There's a link that is provided there below. This can also be found in our Google Drive. So the previous session, the last session we had, session 4, we looked at emerging areas of interest. And thank you once again for all your contributions. Kindly review the implementation considerations that are provided there and submit a response to each. You can either endorse or reject, and also where relevant, you can place any additions, suggested changes, and comments. And if you have any questions, please reach out to any of the members of the organizing committee, reach out to Alice and reach out to Emmy. And we do have a Google Drive. The link is provided in the chat, in the Teams chat. Our agenda is there. There's also the research car park. Please feel free to list any research ideas or considerations that we should take moving forward. And there's also a literature compendium that you can have a look at there. So the link is provided in the chat for the Google Drive. So looking at today's agenda, we will be looking at measuring and monitoring the effective use of PrEP. And this is actually the last of the 5 think tank sessions that we've had. The agenda is outlined below. So right now we're doing welcome and introductions. Our panel discussion will start shortly, and this will be followed at 10:45 by consensus building session, which Alice will lead through our Jamboard, and then we will have our think tank recap session at 11:20, and at 11:35 we will review what you've done, next steps, and close. So I will hand over to Alice to take us through the Jamboard.
Fantastic. I know many of you have experience in the Jamboard, but we just wanted to do one more recap. So if you go to the chat, click on the link in the chat, and then it will take you to the Jamboard for session 5. Let me quickly share my screen so you can see what I'm doing. Hold on 2 seconds. Here we go. Okay, so I see that there's 2 other people in the Jamboard, and the point of the Jamboard is to add in the implementation considerations while the panel discussion is ongoing. So it's an opportunity for all of us to also contribute implementation and considerations for monitoring and measuring. So what you do is you go alongside the left-hand side. There's a number of different tools. You use the sticky note tool. You type in here your implementation consideration. You press save. Whoops, be good if I could spell. You press save. You can change the color if you want. You can then also move it around the board. So if you see other implementation considerations that may be similar, you can move it close to those to try and group some themes. So just another example. So you go along sticky note, pick a color, you type here, you press save, and then you click back on the Jamboard and you can move it around. And you can keep this open in your web browser while you stay on Teams. So that's my quick demonstration there. Back to you, Mopo.
Thank you, Alice. So right now, let me take this opportunity to introduce our panelists for today. We've got 3 panelists. We've got Ms. Gertrude Mncube and Mr. Daliso Mumba and Mr. Andreas Yan. So I'll start with Gertrude Mncube. She is the National HIV Prevention Coordinator for the Zimbabwe Ministry of Health and Childcare. She has spearheaded the introduction of the new evidence-based interventions in biomedical prevention, including PrEP. So PrEP in Zimbabwe. So we're very happy to have her with us today as one of our panelists. And I would also like to introduce Mr. Daliso Mumba from the Ministry of Health in Zambia, who is the civil society coordinator at NEC Zambia, and currently oversees, among others, the GFTAM financing targeting HIV services to key populations and the implementation of PrEP within the country through a task force. And lastly, we have Dr. Andreas Yan, who's with ITEC Malawi. He's a clinical epidemiologist with 20 years of working experience in Africa, primarily in HIV. He has worked in the academic and the program sector, and he has profoundly contributed to the National Art and PMTCT program in Malawi, with innovative strategic information systems and policy and initiatives such as Option B for PMTCT, which has been adopted as a global recommendation by WHO. This was in 2013. He has contributed as an external expert on the WHO Clinical Guideline Development Committee since 2012. So welcome to our panelists. And we will then begin our sessions shortly. Can you all see them? Yes, are your cameras on as we begin this discussion? So then we will start. I think we will start with Dr. Andreas. If you can tell us, what has your experience been with monitoring PrEP implementation amongst adolescent girls and young women in Malawi?
Thank you. So it's a pleasure to join this think tank, and I'm afraid I've missed all of the other sessions, so I'll be educated by my fellow panelists and by the colleagues joining us on the chat. So I just wanted to briefly give a very small background, because I think Malawi is probably behind several other countries in the region in terms of PrEP implementation. And there are some reasons for that. I think one of them is that we've had a number of demonstration projects that have met a few bumps essentially along the way. So we've had one implementation study in Lilongwe amongst adolescent girls and young women, where PrEP was given in the context of a formal study to measure the uptake and the retention. And the findings have been fairly disappointing. We've learned a number of lessons there. But we've essentially now completed the design of the monitoring system for the national program. So I'm working for the Ministry of Health, for the HIV department. And so my perspective is very much on the kind of public health aspect of what is feasible within a Ministry of Health system. I think what we've seen for PrEP, certainly up until now, is that it's very much dominated by implementing partners with certainly much better resources in terms of implementation, but also in terms of data gathering and reporting. And so the challenge really that we've had is to try and trim it down to something that is scalable, implementable, and also has a chance to be sustained in the hands of a much less well-resourced setting in the Ministry of Health. I think there are a few important considerations that I wanted to mention that I think need to be discussed in terms of the M&E system, certainly for PrEP. The first thing is that Malawi is not KwaZulu-Natal, so in terms of HIV incidence in all populations, but particularly amongst adolescent girls and young women, incidence is much lower, still high, but much lower than in South Africa. So I think the aspect of targeting is really essential and needs to be incorporated in the monitoring systems as well. And just to illustrate that, I wanted to just briefly share a few numbers. I'm an epidemiologist, so that's kind of my turf. But so we've engaged in a formal impact modeling exercise in 2019. We've used the GOALS ASM model. I think many of you might be familiar with it. And we've looked at various scenarios for scaling up PrEP for adolescent girls. And we've specifically looked at geographic targeting. So we have estimates for districts, at least rough estimates for incidents that allow us to do that. And so I think an interesting take-home finding here was that firstly, PrEP implementation to a meaningful, epidemiologically meaningful scale can be a significant budget driver. So for example, the first scenario we've examined is to cover 20% of all adolescent girls who are assumed to be in the higher risk subgroups in all districts with PrEP. That comes to an annual budget of $62 million with an average cost per infection averted of $108,000. And we've looked at more targeted strategies for the highest incidence district in Malawi, in Blantyre, of folk covering only 8% of adolescent girls in that district alone. And that still comes to $25 million budget per year and $60,000 per infection prevented. So I think the key in terms of monitoring such a program will be to have at least enough strategic information to see if the selection of participants is adequate, and if there's an appropriate follow-up in terms of the risk monitoring as well. So we've kind of tried to incorporate that into the patient cards, the client cards, and the registers we've come up with. And then I think the other important aspect, of course, is the adherence. We've all been concerned about this. We know that PrEP works really well if adherence is good. But as soon as you lose the adherence in the risk episodes, you get to very disappointing results. And I think that's key for a national program to consider, that there has to be some measure of adherence and retention in the program to provide essentially the information that we need to steer forward. I think in terms of the actual M&E system, there are just maybe two aspects I wanted to highlight that we've been grappling with and we've come up with some solutions for. One is firstly, of course, that PrEP is an open cohort. So these are individuals who come with episodes of risk. And so there's an expected start and stop and potentially restart, of course. So that's something that's quite difficult to manage in terms of a monitoring system. It's essential, I think, that we have primary follow-up outcomes documented to make any sense of the data. And by that, I mean things like loss to follow-up, of course, so unknown outcomes. Deaths will be few, but of course, that has to be covered as well. And then within the retention, I think we need to, of course, monitor the seroconversion, so HIV positive, HIV negative. It's essential, I think, to look at toxicity, and then to monitor the ongoing classification of risk. And then, of course, we have to also deal with potentially transfers between facilities. So all of that makes for a fairly comprehensive and fairly complicated monitoring system. And we've been struggling to think how this could be brought to scale within the constraints of a ministry program. And so I just wanted to say that I think that we're at the very beginning. In fact, we have now a few hundred clients who have started on PrEP, primarily amongst implementing partners who've started the PrEP implementation for female sex workers. They are very differently resourced, and in terms of their capacity to make even active follow-ups, it's a whole different ballgame. But I think to make it meaningful for a national program and to really have an incidence effect that's measurable at the population level, we have to bring it to a much larger scale. And I think that needs to be the focus in terms of the M&E system as well, to come up with something that is scalable to a meaningful level and sustainable. So let me just stop here in terms of my monologue and invite my colleagues to chime in.
Thank you very much, Andreas, for those insights. I think you're bringing in very important and thoughts that have a lot of people, a lot of us grappled, thinking about how do we do this, complicated M&E system, how do we do our targeting, how do we constantly define need as the need for the individual changes, and how do we capture that? So very, very interesting insights. So I'll now move over to Gertrude. So Gertrude, in terms of Zimbabwe, what has been your experience in Zimbabwe as you've been transitioning from demonstration projects to national scale up? And can you also enlighten us a bit on the database that you have, and as well as the partner dashboard? Thank you. Over to you, Gertrude. Sorry, Gertrude, you are muted.
Sorry. Good morning, colleagues. Good morning, everyone. Sorry for that. I'll start from the beginning, where Zimbabwe, we adopted pre-exposure prophylaxis. And when we adopted it, we said it will be in a phased-out approach. And when we looked at that phased-out approach, we actually said it has to start where I think we've got resources to start with, to implement pre-exposure prophylaxis. And this was where we're saying we had resources. We actually looked at the DREAMS districts in the country. By then, the DREAMS districts were about 6 in the country, but we started on the 4 districts in the country. Maybe just a lesson which we learned from Zimbabwe, we didn't actually say the implementing partners should actually start the PrEP. It actually started as a government initiative when we adopted. And then when we looked at that, the demonstration projects were actually to give us lessons on saying, what is it that we need? Who is the target group? Who is supposed to be getting PrEP? And already as a country, we had that technical working group. That technical working group involved the funders, the implementing partners, Ministry of Health, our M&E colleagues, and everyone else. So with that, we actually said, what is it that we need to do? We actually said, we need to come up with data collection tools so that we need to see what we are collecting. And at the same time, we even need to come up with the demand creation tools, IEC materials, and all that, and then the capacity building. And then that actually helped us. What we then, after the demonstration projects, we had these demonstration projects for actually 1 year, while we were actually looking at our implementation plan. So in 2018, we came up with PrEP implementation plan together with our partners, working together, giving us information as well of what is happening through our technical working group. So then we looked at monitoring. We looked at the data collection tools which were actually being used to monitor, and then we transitioned it to our national database. Like we have got the DHIS2, which has got all our indicators, especially for our HIV programming. So we actually looked at what we're using during the demonstration project, and then we said, what are the key indicators which we need to transition into our DHIS2? So as I speak in Zimbabwe right now, PrEP is part of our web-based DHIS2, where in every district we have primary data source where we've got registers which we modified after our demonstration projects. And then with those registers, we've got our monthly data collecting tool, monthly report form, which actually is entered into our DHIS2 at district level, and it comes to the provincial level, and then it comes to the national level. So at a national level, we are able now to see how many clients have actually been initiated on PrEP. And which are those actually target groups which we came up with? It is the adolescent girls and young women. We've got the female sex workers, and then we've got the MSM, and then we've got serodiscordant couples. And the other indicator which we collect is those who actually, others who perceive themselves to be at high risk. So we collect using that information. So we realized again, because some of our implementing partners, they were not entering data within our DHIS2. So then we actually came up with saying, why is it that it looks like looking at the number of supplies, logistics, or commodities of PrEP which have been provided is not actually tallying with what the information which is in the DHIS2. So what we did was we came up with a sort of like a dashboard, which our implementing partners, they are actually using at the same time using the DHIS2, so that us at national level, we are able now to look at how many people have been initiated, and then the DHIS2, and then we say, partner, give us as well your data so that we see, we compare, we triangulate the data to say, is it the same number of initiations and all that? Because some of them, they do mobile initiations, and at the end of the day, maybe with that monthly report, they don't report within that monthly report and then send it to the DHIS2. So we have actually come up with that dashboard, which shows us the number of new initiations disaggregated into age groups as well, which is the age and all that, and who is actually even, that dashboard actually is even informing us on the continuations as well, how many people are actually continuing on the pre-exposure prophylaxis. So for us to come up with that, for that monitoring, which we are actually looking at, we had actually to do a lot of issues as well, a lot of training, and it was really a challenge that at times our data was not within our DHIS2. So that's what we're actually looking at as well. But I can say now, pre-exposure prophylaxis is in our national the district health information software, our web-based database, and we are able to, here and there, we have got challenges, but we've tried to say how best we can overcome those challenges and all that. So this is what we have actually been doing. But what we can say, we learned lessons from the demonstration projects on saying who is our target group, how should we monitor, how should we actually make our registers user-friendly. We are still using that, but I'm looking at the long run, we need even to have an electronic monitoring system. And as a country, we are actually working on that, to have an electronic monitoring system, and our PrEP register will be part of that electronic monitoring system. Thank you.
Thank you very much, Gertrude. That is actually quite exciting. It's commendable that within a very short space of time, you've really moved the PrEP program forward. The fact that now PrEP data is actually reported through the national database, it's actually quite commendable. That's great. We will move over to Mr. Daliso. Can you tell us more, Mr. Daliso, about your experience with monitoring PrEP implementation in Zambia?
Okay, thank you very much. Thank you very much. Good morning, everybody, once again. I hope everybody is staying safe within the current pandemic. So I think similar to my colleagues from Malawi and Zimbabwe, I think with Zambia as well, we did start off PrEP implementation with demonstration projects. I think this was around 2016, 2017, with about 2 sites, which were mainly supported by University of Maryland, which is one of our key partners for PrEP implementation. During this period as well, we initiated the development of the National PrEP Implementation Framework and Guidance, which basically was our guiding document for full-on scale-up for PrEP services within the country. And this document was developed in collaboration with our various implementing partners, Ministry of Health, as well as other institutions. And this document provided some minimal guidance, not too much of it. I think around this time, even WHO hadn't provided significant guidance around PrEP M&E. So this guidance basically provided a few indicators which were mainly focusing on the proportion of sites, ART sites providing PrEP, the number of individuals who received oral PrEP to prevent HIV infection, as well as the total number of old and new active PrEP clients, which is basically PrEP new and PrEP car. The document also provided guidance, a list of tools which could be used for providing PrEP services, mainly the registers, the initiation form, as well as the follow-on form. The tools were basically there to provide monitor safety and effectiveness of PrEP implementation. So during our initial phase, of course, we didn't have so much information when it came to PrEP M&E, and we were basically looking at these three main indicators as well as the tools. However, we do understand that PrEP monitoring and evaluation still remains a significant challenge, and mainly because of the absence of population data in the country. This is basically looking at the national targets and indicators. Most of the targets that we do have are program-based targets, which our partners themselves set for themselves, or PEPFAR, for example, sets for themselves. Also to mention that PrEP in the country is mainly supported by PEPFAR. They are our main supporter for PrEP implementation in the country through their implementing partners across the country. During this period as well, we did see a significant increase in the number of sites providing PrEP within the country. I think at the moment, all provinces in the country or all districts in the country do have PrEP sites. So like I was saying, we don't have population-based targets or indicators. We're only at the phase of where we're more or less coming to set up some targets which you can use for PrEP implementation. The other challenge that we have as well is that we're poor integration of our PrEP data into national M&E systems. So unlike our colleagues in Zimbabwe who are way ahead of us, we haven't yet integrated most of our data into the national M&E systems. We rely on our partners from PEPFAR who provide us with data on a semi-annual basis through the PEPFAR reporting system, also known as the DATIN. However, we're not just sitting back. I think we're making strides to move forward, even as we've scaled on PrEP to a national level. We understand that M&E remains very key for us to implement PrEP. And what we've done as a country is we've started the development of the national M&E framework for PrEP. Basically, this document will be a guiding document for PrEP implementation, for monitoring PrEP implementation in the country. And the key main objectives of this document is basically to standardize monitoring and evaluation of PrEP services. So like I mentioned, we don't have an MOH or Ministry of Health approved monitoring system. So we want to standardize so our partners can all report using the same tools and report within the same system so that this data can be available at national data, and we don't always have to rely on our PEPFAR partners to provide us with this information. We also want to ensure that we set targets, national targets and indicators, so we can monitor and supplement indicators along the PrEP cascade. Like I mentioned as well, we don't have national indicators. Most of our indicators or targets rely on PEPFAR targets, which partners use to reach out to the various populations. We also want to promote a data-driven approach to PrEP services delivery for program improvement and decision making. And lastly, we also want to present a cost-effective methodology for PrEP. So this document at the moment is currently being reviewed before publication by the Ministry of Health and remains our key guiding document for PrEP implementation. Now, when we talk about PrEP, for example, for adolescent girls and young women, I think adolescent girls and young women are one of the largest populations that we've reached out with PrEP services. I think there are numbers amongst all other populations, which include female sex workers, men who have sex with men, pregnant and lactating women, serodiscordant couples, and so on and so forth. They're always adolescent girls and young women are always in the higher percentile, so usually ranging about 34% of the population that is reached with PrEP services. Of course, there's still significant challenges with reaching out to services for adolescent girls and young women, mainly because of the social norms, also access to where we can provide these services as well for the younger populations, also stigma and discrimination associated with receiving PrEP services. Girls fear they might be perceived as being promiscuous and so on and so forth. However, through program data, we continue to monitor the number of girls that are accessing these services. And of course, the biggest challenge, like in Malawi, is that we don't have a high retention for people on PrEP. And this may be due to various reasons. Maybe due to drug fatigue, it may be due to the side effects, it may be due to diminished risk, it may be due to stigma and discrimination, it may be on the end of the client themselves, so perceived stigma, or it might be poor service delivery from our healthcare workers. So we understand that we still have to constantly monitor and collect this data for us to improve our services, particularly for PrEP for adolescent girls and young women. And I think that is one of the reasons why we want to roll out this document on the PrEP M&E for monitoring PrEP implementation within the country, the M&E framework. And hopefully, once that provides guidance of how we can use the program data to inform decisions and where we can improve in order to improve quality of service, it will be better for a country as we move towards full-on scale for PrEP. We're also in the process, I'd like to mention that we're also in the process of just starting to do some demonstration projects for the DVR as a country. So those are some of the things that we also want to learn from PrEP and see how we can, the lessons we've learned from PrEP can be taken onto the DVR, which should come onto the market in the country within 12-month period. So in a nutshell, I think that is where we are as a country when it comes to PrEP M&E framework. We still don't have a national system, and we're working towards that through the PrEP M&E framework. Thank you.
Thank you very much. Thank you very much, Mr. Daliso. I think it's also very exciting to see that there's a lot of work currently going on, even in Malawi, and the fact that we are really thinking about M&E and the role that it plays in ensuring that PrEP is provided and provided well, and to ensure that it's effective, and we can at some point be able to look at its impact as well. I think what's also coming through from Dr. Yan, I'm just thinking about it, that talking about effective targeting, so that as we implement PrEP, it remains cost effective. How do we define risk? How do we ensure that we strategize in a way that we are able to scale up? Because if it's still too expensive, then we really cannot see any benefit to it. And touching on what Gertrude was saying about moving on to online platforms so that we are able to have a full view of implementation and what's going on. And you talked about, Daliso, about a national framework. I like that it's actually a well thought out process when it comes to M&E. So it would be very interesting to hear what you have to say in a couple of years, perhaps when you're on a platform like this, once again, Mr. Daliso, sharing your experiences with implementation. So just to follow up, Andreas, what has worked well for other specific interventions when it comes to monitoring the effective use of PrEP? Are there any transferable lessons that you've learned that you would like to share with us?
Thank you. So yes, I mean, as I said, we're at the very beginning of implementation outside of demonstration projects. So I think I wish the meeting was 6 months later. We would have probably more to share. But I wanted to say that I think we have modeled the entire M&E system very much on the ART program monitoring system that was designed, in Malawi in 2005, so a long time ago, and has been quite successful for a very long time on a purely paper-based system. And it worked, I think, because we have regular supervision of all the sites. So there's an oversight, there's data auditing happening. We're looking at primary records. And I think that has been key for the ART program. And we're hoping to kind of transfer that same lesson over to the PrEP program. From experience, certainly it's been far more difficult to monitor effectively community-based programs because that kind of level of access to primary records is much harder to deliver for a ministry. And I think that that's why I'm also, I proposed in the chat box that, I think two of the kind of key entry points that I can see where meaningful PrEP implementation could happen is within the STI clinics and the family planning clinics, because we have huge numbers of patients or people accessing these services We have routine HIV status ascertainment already, so it's an automatic eligibility check. Essentially, if you have an STI patient who tests HIV negative, it's a fairly safe bet that this patient might benefit from PrEP. And so I think that even without trying to elicit potentially stigmatized behavior, you could very easily make a simple recommendation that somebody might consider taking PrEP. And I think with adequate information, I think that would also potentially make the acceptance much easier, because I think we're at risk certainly of having that key population label on PrEP, which is going to be really off-putting for many people who don't consider themselves to be part of such a subpopulation. So I think that aspect shouldn't be missed from the beginning, also in terms of how we monitor. So we've discussed for a long time internally whether we should even attempt to document stigmatized behavior on a client intake form, or on the client record, because we know that this is going to be a challenge both for the provider as well as for the respective client to disclose, and it might give the entire PrEP program a bad name in terms of being only for specific subpopulations. So I think that might be two things to really think about. I think from my perspective, certainly of working in this program for so long, I think integration into existing service delivery points will be a key to bringing this up to meaningful scale. That doesn't stand in the way of providing PrEP within drop-in centers and key population projects. That's I think a given. But I think that to bring it outside of that realm, I think we have to think very differently. And I think we have to be careful that we don't label it from the beginning as something that may prevent access and uptake in a much wider population that would benefit potentially from it. I had posted a few questions to colleagues because I was just curious if anyone had attempted to do that. So one of the things that we noticed from our demonstration project is that we have actually seen a concerning number of new STI episodes, as well as unwanted pregnancies and a few seroconversions in the PrEP demonstration project for adolescent girls. And I think that will be a key, certainly for a responsible public health program to keep an eye on, to monitor and make sure that we don't, inadvertently encourage, further risk-taking behavior without appropriate offers of prevention measures. And I think that I just wondered if anybody else has any information on this, what's been collected for example, in Zimbabwe, because I think Zim is further ahead of us. It just struck me that this is a really important part beyond, counting the PrEP initiations, looking at person years on PrEP, so the kind of exposure time, as well as these secondary outcomes that strike me as really important to keep an eye on. Over.
Thank you, Andreas, very much for those insights. And I would like to encourage colleagues that please use the chat. Andreas has posted the question there. Can we start engaging with it? Perhaps when we have time, we will talk about it. We'll bring it up and talk about it. But please feel free to comment and respond to the questions that are on the chat. So now, Gertrude, going back to Zimbabwe, we talk a lot about engaging adolescent girls and young women in our efforts, as we do. We with them, we cannot do this without them. So how have you incorporated other types of data and perhaps insights as well to inform your programming for adolescent girls and young women in Zimbabwe? Over. Gertrude, please
Thank you so much. Thank you so much, Mopo, for that question. Maybe looking at adolescent girls, I think I even alluded to the fact that we have our DREAMS districts where we've really interacted with adolescent girls. And initially with 16 districts, but now we've got about with 6 districts, but now we have got about 16 districts. That's through PEPFAR. And through Global Fund as well, we have the DREAMS districts where we are actually interacting with our adolescent girls. But when we started PrEP, what we did was what we call empathy, insight, and prototype of adolescent girl. This is a way of actually trying to spend your time. We had our colleagues who actually looked where we're looking at demand generation, where we actually had time where we spent with adolescent girls and discussing about PrEP, where we spend our life like you spend a day with an adolescent girl, and where we're saying what are the barriers if we are actually talking about PrEP, what do you think could be the barriers, what will be the facilitators, and you spend your life in a day in the life of that adolescent so that you will understand better, especially when they are saying we are interested in pre-exposure prophylaxis, but we've got barriers. And some of them whom we interacted with those young women selling sex, where they actually were to understand better, to say if we say you need to access it in a health facility, what time should they come and all that. So we have actually even developed a communication strategy, and in that communication strategy we've even used a human-centered design where adolescent girls have actually told us who are their influencers, what are their barriers, what we need to consider and not. And that actually helped us into saying, like now we are actually looking at the issues of continuation of PrEP when we are monitoring, especially with the adolescent girls and young women. We are, especially with the, maybe because we start PrEP from 15 years and above for those who are supposed to be given PrEP. So we monitor them and see what is happening. So all those insights which we got from them, the target audiences, they actually helped us. We actually, even with the PrEP program for the adolescent girls, we come up with what we call peer supporters or PrEP champions, which have actually helped us as well, where if we initiate someone on PrEP, they either actually they live with those adolescent girls there, they actually identify those maybe who are at substantial risk, but when they get into the health facilities, that's when we use that screening tool to really see that they are really at a high risk of getting HIV. So we use all those peer supporters. We use even the PrEP champions, which has actually helped us as well in the monitoring. And if they've got, whether they've got challenges with access of services, we actually use those people to actually help us as well in the monitoring as well for effective use of PrEP with adolescents. We have sort of like an insight on their journey mapping to say what is it that they need. Do they need, like initially when we started, we're actually in our health facilities of giving PrEP within the OI clinics, but then the adolescent girls, with interaction with them, they said, no, is it not possible that we can even get PrEP within maybe in the outpatients and all that? So we have, in other areas, we've actually made a way to say these adolescents, due to the interaction which we have got with them, we actually get those services. And some of them, they've even said, maybe we need you to come to our support groups where we meet and then maybe initiate PrEP in those areas. So we've actually interacted with them and listened what they are actually saying and tried by all means to actually be able to give them such kind of services. So I think what I talked about, the empathy, imaging, prototyping, and even the human-centered design, and even the issues of PrEP champions and peer supporters within that, they've actually helped us in actually to monitor and see what the adolescents need on their barriers and facilitators as we implement or as we scale up pre-exposure prophylaxis amongst them. Thank you.
Thank you very much. Thank you very much, Gertrude, for those insights. It's actually quite exciting to see that you are engaging young people, not just for demand generation, but across the whole continuum of PrEP implementation, and getting their insights and their thoughts on how these services should be delivered to them, how monitoring should be done. So that's actually quite exciting. So we'll just take one last comment from Daliso. We've really run out of time. I apologize that I have to tell you that before I engage with you, but if you can really make it quick, that would be great. So, I mean, we are all excited to hear that you are implementing at scale, and I think the plans that you have are really great. So we would just if possible, can you tell us more about the next step, the steps you actually took from going from monitoring in a demonstration project to now demonstrating, monitoring at scale? So how did you move? How did you do that? Monitoring at demo level and now moving on to scale. How did you do that? Share those learnings if you can, please. Thank you, and over.
Okay, so I think very quickly, I will mention that I think the key thing when it comes to all of our implementation of PrEP is that we developed a task force which was spearheading all processes, whether it was M&E, guideline development and training and so forth. And this task force basically encompassed the various implementing partners, line ministries, experts as well as our donor agencies such as WHO, USAID, CDC, and so on and so forth. And in essence, the purpose of this was for us to work collectively and provide guidance on how we can move from a demonstration project to a national full-on scale-out. And like I mentioned, I think the key issue as well was us developing a guiding document, which everybody can relate to when it comes to PrEP M&E. As much as it wasn't sufficient, we've moved on now to develop the national PrEP and M&E framework. So we've taken a more or less of a gradual process from a demonstration to having the guidelines to having now the M&E framework on M&E. But also what's very important is training of our healthcare workers or our data collectors on M&E persons for them to understand what type of data to collect, how to use this data, how to report this data, and how to interpret it. It's very, very, very important. Also, we need to educate the community themselves, the beneficiaries. They need to understand, for example, when it comes to follow-on visits, what is it that they should ask the doctor or they should ask the clinician to check on them. So in a very short, not to take too much of your time, I think that is how we've taken the process from demonstration to full-on scale. I hope I did that under a minute. Thank you.
Fantastic. That was brilliant. Thank you very much, Daliso. So now, we'll open up to questions from the floor. But before we do that, colleagues, I want to encourage you, please make use of the Jamboard for your suggestions and questions. It's really fantastic. Just go have a look at the Jamboard and you'll see what others have done, and perhaps it will also prompt some questions from you. But if you have a question, put it there. It's actually a fantastic platform to use, the Jamboard. It's a lot of fun. It has a lot of colors. So you should have fun engaging with it. So now we have one question that we'll direct to our panelists, and perhaps others can also input. And if they have comments, seeing that this is actually a learning platform for all of us. So the question that we have here, which was posted on our Jamboard, is, has any M&E system been able to measure person years on PrEP? Initiations alone are not a very meaningful measure for PrEP implementation. So I would direct that to you first, our panelist, for your thoughts and around the question. Over. So I'm not sure who would want to go for it first. Shall I start with, I see Andreas and then Daliso.
So it was actually my question, because suddenly we don't have that data. We have it from a demonstration project, and I have to say I've been involved in the analysis of the data that's been collected, and it's a real struggle. It's an interesting intellectual challenge. And I was just curious, given that our neighbors are further ahead in terms of implementation, if they've attempted to look at that. Because, I think, of course, in terms of the impact, we're looking for as much coverage as possible in terms of risk episodes with PrEP exposure. And so I wondered if anyone has attempted, I know that the PEPFAR indicators are quite limited. It's only new initiations and currently on. But that doesn't really tell you very much about the person years on PrEP that we've achieved in the program. And I think that's the key, of course, for measuring effectiveness and impact. I was just curious if anybody had thought along these lines and if you've had any luck trying to construct that from your data. Over.
Thank you very much. Thank you for that clarification, Andreas. So we can have a discussion. I'm not seeing any hands right now. So perhaps some of our colleagues who are also on the call can actually weigh in, especially from countries who've had a lot more experience with implementing PrEP. It would be great to hear your inputs on this question. I will repeat the question for the sake of those who may not have heard it. Has any M&E system been able to measure person years on PrEP? Initiations alone are not a very meaningful measure for PrEP implementation. Yes, I think we are all aware that people initiate today and they drop off tomorrow. We don't know whether it's because of poor engagement or their risk has changed. So in terms of looking at effective use of PrEP, meaning that when they need PrEP, they are on PrEP. So how do we have any? Okay, we will, as we're waiting for more inputs from our colleagues. Daliso?
Hi, not at the moment, but I think it's something that I think before we finalize our M&E framework, we'll look into. So we haven't yet started looking at M&E on person years. Yeah.
Okay, so I'll have a look here at the chat as well to look what other questions colleagues have posted. Please feel free to raise your hands as well so that that may be easier. Gertrude, do you have any inputs?
I was saying not at the moment of the person years, but what we've been monitoring is actually on the continuation. We have a cohort of actually clients where we'll actually be monitoring the continuation. And maybe I must say, maybe there's need to do that, but for the monitoring the person years, but on the continuation, as Zimbabwe, we've actually data to say, and on average, we've actually seen that people, they continue on pre-exposure prophylaxis for 6 months. But if I'm looking at adolescent girls on the data which we have, most of them, they actually fall off after 2 months and all that. But those are these areas as well where we are actually engaging them to really finding out why they discontinue and all that. Some we've got actually the reasons why they are discontinuing, but on the number of years we haven't. But we monitor, and especially even our dashboard, it actually shows us to say for how many months or for how many. But the longest who continue for maybe about 9 months is about the serodiscordant couples as well as some female sex workers. Thank you. I hope it's useful information.
Thank you very much. Much useful. Gertrude, I think this is a great platform for a lot of us to learn from what others are already doing. So another question we have, we know from consultations and emerging evidence that there's a need for community to be strongly involved in any PrEP programming. I mean, how can it be brought to the table, and how could we design monitoring systems that would be able to capture this? So we know that community engagement is very important. Strategic engagements with communities are important in promoting the uptake and retention on PrEP. But how then could we meaningfully measure this with our M&E systems? That is the question to our panelists. Over. Are there any hands? Let me just, so I'll leave that over to you. Dalisa, would you like to get started?
Okay, I think in any type of programming, involving the beneficiaries themselves is always key when it comes to implementation, whether this be through M&E or whether this be through communication, through trainings, through providing the relevant information. Sometimes it may be difficult to measure community involvement. It depends on what you're measuring. For example, are you measuring how much information the community knows about the certain program? Are you measuring, for example, how many people in the community are receiving that service? I think constant program data, surveys as well on a regular basis will help us understand how well the community is involved in a program. And usually this can help us understand the level of knowledge that the community has in that program and how well they are involved. We could also use our community health volunteers. They're very key. I think most of us do have community health volunteers on the ground, and they can help us assist. They can help us assist and gather information on what the community knows and how well the community is involved in implementation. Especially for programs that relate to HIV, we're still well aware that, for example, even condom programming is still a very difficult topic in most rural communities. Even PrEP, for example, there's still a lot of misconceptions when it comes to PrEP. But working with community leaders as well and understanding how they can help us reach out to these communities is very, very key. For example, on some of the projects that we've worked on with key populations, we've understood that working with key populations, civil society organizations, or gatekeepers within the key population community is very, very important in reaching out to this community. You find that most of the time, key populations will not be open even for other services beyond PrEP to receiving these services if they're not working with people who they're familiar with. So sometimes working with people from the community or getting community health volunteers who are part of this community can help us assist reaching out to these communities, and it will also help us understand how well the community has been involved and to what level they understand the services that are being provided to them. It's a similar situation with adolescent girls and young women. We all know that it's easier to have peers who are adolescent girls and young women reach out to their own adolescent girls and young women rather than use older people to reach out to them, because only then will they understand these services from the people who are part of them as well. So thank you.
Thank you very much, Dalisa, for those insights. I was just also thinking here about CAP surveys, knowledge, attitudes, and behavior surveys to assess. Those are also very important before we start, as we are going through, when we've started with implementation, just to weigh in to see how perspectives and how attitudes are changing within communities. I would also give over now to Gertrude. Do you have any perspectives on that to share? On how we can meaningfully measure or monitor community engagement when it comes to PrEP implementation? Your thoughts?
Okay, I think like the issues of surveys and like what I've alluded to, that we have what we call PrEP champions, especially for our adolescent. It's sort of like a way of actually including as well the communities as well. And I think what, especially with our HIV programs, where we are now sort of like encouraging communities to sort of like have community-led monitoring, where we're actually looking at maybe different subpopulation as well, where we are working with communities to really look at community led monitoring of our HIV programming as well. And I think these ones, they've actually assisted as well. I'll talk of the key population program, where we have got what we call community-led, where the subpopulations for the KP program are actually assisting that. I think from the lessons which we have learned from the KP community-led programs, we can employ them into our PrEP programs as well, not only for adolescent girls, but for the other populations at risk. Thank you.
Thank you very much. Before we take the last question, Andreas, do you have any perspective on this? Any insights to share? Over.
So, I mean, echo the sentiment. I think, that of course the kind of information messaging to the community is essential. I've just, posted a little anecdote in the chat box because we were so struck by that. So we've seen a decline in access of family planning services because there's some perception going around that women might get vaccinated against COVID, which seems to be something that people are trying to avoid. So I think, it's something that you have to almost anticipate and do, appropriate work in terms of messaging before you attempt to roll out anything. And I can relate to this certainly for the key population projects. It's a far easier game than I think to bring that kind of information into the general public. And I think, that's why I said I think integrating into, say, family planning or STI clinics might be a much more promising strategy. But it's essential, I think, to have people understand and have appropriate perceptions about the risks and the benefits of this intervention. And I'm not sure what more can be done, but I think we've probably collectively not done a fabulous job in getting ready for this. Thank you.
Thank you very much for that. Thank you. You've provided to the three of you. You've really provided great insights on these topics that we've covered today. And just to extend the question that we had earlier on being able to measure person years on PrEP. I do believe we have academics and epidemiologists and all sorts of great people on the call. So if they could also weigh in on that question, and I think it's Andreas would really like to get feedback on that question. So it would be great if we could just discuss it. I think it's a very important question, and yeah, just to share some thoughts. So now we're extending the question to the floor. I think this one, everyone wants to think about it some more. I'm not seeing any takers. And Andreas, I'm not seeing any takers. I want to encourage you once again, though, colleagues, please make use of the Jamboard, post your questionnaire and comments, the comments that you may have. Alice, would you like to take us through the Jamboard? Maybe one or two questions that are there, or should we proceed?
Thanks, Mopo. I'm happy to share the Jamboard. I think it aligns quite nicely with the conversation that's had amongst the panelists. I see we do have a number of fantastic implementers, implementing partners, academics, national level people, and I do encourage you to continue to share some of your monitoring considerations from your different areas of work. Let me quickly share my screen to pull up the Jamboard. All right. Can you see it there? Okay. Wonderful. Okay, so I think we have some kind of key indicators that we need to be measuring that were mentioned in the discussion. I think Andreas has put here as well some outcomes that they look at. I think that was you, Andreas. So we've got things around, toxicity, ongoing classification of risk, transfer to other clinics, really highlighting that it is, a number of these indicators other than initiation can be quite complex as well. We heard quite a bit around how do we, the need for integrating within existing governmental M&E systems. We heard a great example around DHIS and some of the kind of learnings and the adaptations from there, the importance of aligning implementing partners with the DHIS and other national tools to make sure that the data is triangulated. Again, the key importance of the national leadership, not just for implementation, but also for monitoring, making sure that this is starting right at the beginning in demonstration projects. We heard that from Zambia, also Zimbabwe, and obviously Malawi as well. I think some of the examples were around kind of task force dashboards that are really have helped to facilitate some of the coordination and also the contribution of the different partners to also, also around guidance and documentation of, standard operating procedures and tools and how things should be. There was a little bit around, the assessment, and this is maybe also a bit of the a good one for our research car park around, the demand creation activities and how we actually measuring or assessing the effectiveness of those for PrEP. I don't know if anyone in the room, the virtual room, has any examples of how they've done that, maybe through their demonstration project or research, where they've really seen what demand creation they did and whether that was effective. All right, and then we have, broader demand creation, and we discussed that, I think, at the initial session, our opening session, and the importance of that, and I guess is also how do we monitor that and the effectiveness of that. Then we also had some other questions here. Our person years on PrEP has not yet been answered, so if anyone else wants to contribute to that. And then some questions around how are we using this data to improve programming, and is the data continuing to be collected and tracked at national level? So again, maybe a little bit more about the role of national level data systems. So this one's just come in about acceptable thresholds of rates of toxicities, new STIs, unwanted pregnancies. And should we really establish what these levels are and what is expected and how we intervene? So that's a new thought that has just come in. We haven't discussed that one yet. So Mopo, over to you to open up to our colleagues to see if they have any additions, other considerations. We've got some Q&As here. Oh, sorry, I forgot this one. We talked a little bit and someone has added around, the PrEP championships and how they also are helping, to monitor effective use as well. And it also gave examples of community-led monitoring. I think it's great to see that mentioned as well. So if someone wants to add a sticky note on community-led monitoring, please go for it. All right. Any hands up? Can you see any hands?
No.
Oh, you've
no takers.
It's been 5 sessions. Everyone's all talked out, hey? No more sharing. Everyone's done. Anyone with the demand, assessing how they've monitored and assessed the effectiveness of demand creation? Anyone want to share about that? Any more examples or?
All too hard.
Yeah, and Andreas, you've got the most energy. It's because you've only joined for the last session. I think everybody's a bit tired out.
Yeah.
You've exhausted them.
No,
it's
fine.
They're
hard questions.
Any other
I was
community?
going to say,
Yes.
I think the answer to much of the kind of the questions we've posed in terms of how to monitor and interpret that data is it probably does. There's probably no way to avoid an electronic data gathering system to some extent, involving individual visit and client level data. And I hear that also, Gertrude, I think, had mentioned that. I think, this is something that I guess is being discussed in all countries. The experience has been certainly also for us that this is not an easy walk in the park. So electronic systems provide much more information if they work and if you can sustain them. And I think, to answer some of these questions, there's no doubt in my mind that it will take that. But I think we have to be conscious that this is a big investment in terms of the initial investment, but then also, to keep it going. So I think that might be something to highlight on the Jamboard as well, that, I think there's probably no way around an individual client and visit level electronic system to monitor the PrEP program in the level of detail that we're envisaging. Over.
Great. Thanks, Andreas.
Thanks.
I don't know if I'm just trying to think which countries may have electronic. I think maybe it's just South Africa in the region. Are there any other countries? Mopo, do you know? I think no.
In Zimbabwe, we are actually using the EHR, but the PrEP module hasn't not been. But like it's really in few sites as well, where we've put maybe our other HIV modules, like HIV testing, is already there and all that. So, but it's work in progress for electronic health records where we are using it. Thank you.
Okay. That's great. Any other countries want to share their experience of electronic data records or steps that maybe you are taking to do this? All right. I think the crowd has spoken. It's unanimous. I'll leave it for you to close this.
I'm also just thinking, Alice.
Yeah, go for it.
I think we may not have enough bandwidth there.
Are you there?
Oh, yes, Alice. I was just, considering all the other PrEP options that we're getting, the ring, Cabernet. When we are thinking about these systems, we should also think about how we can integrate all the other options that are in the horizon. Right now, we just have one. So in terms of the M&E systems that we are envisioning or that we have, to what extent can they also accommodate all these other options that are in the horizon? And also in terms of impact that we've started implementing, other countries started implementing in 2016, perhaps at the demo stage. But how would we look at this? How will we assess impact? So if we, this monitoring, even at implementation stage, it's very important, at least so that it can inform subsequent evaluations that we would want to undertake to look at the impact that PrEP has had on reducing the incidence of new infections, So that was just the thought.
Great thoughts. Anyone want to respond to Mopo?
If I can just come in there, because I think this is the key, and I completely agree that this is what we should all be focusing on. I think the challenge, as you know, just in terms of the data required, is that you need a comparison group. The real challenge we have is that it's actually very difficult, as we know, to establish what is the expected incidence in a population that we're recruiting for PrEP. And outside of a kind of trial setting, that's really hard to do. We have, population-based estimates for even down to the district level potentially, but of course they have huge uncertainty bounds, and so it's difficult, I think, to make any comparison with, potentially rates of seroconversion within the PrEP program And then, of course, the challenge is that we know very little about what happens to clients who have discontinued PrEP, so who are not coming back to the PrEP facility, for a follow-up and a follow-up test. And so it did occur to us that, one thing to consider at least might be to explicitly and routinely ask for previous PrEP use in the testing program. So if you capture PrEP use or prior PrEP use count or prior PrEP use in the HTS register, you get at least some insight to how many seroconversions you might get among people who have been or are currently on PrEP. And I think that that doesn't answer fully the question about the desire for measuring impact and the effectiveness, but I think it does give you, at least from the monitoring perspective, a signal if there's a concern that you have not achieved the ultimate goal of reducing your incidence by 80% or more. So I think that's one suggestion. I think to certainly consider. We need to think about how we can integrate the PrEP program into the other existing services, and just adding the element of PrEP use into the testing data could be very useful, and I think meaningful for a national program. Mm-hmm. But other thoughts are welcome.
Thank you very much, Andreas, for that. I don't see any hands. I think that's I hadn't actually thought of it in that way. I hadn't thought about asking that question around PrEP use for those who are testing for HIV. That's actually quite interesting. Yeah. I don't see any more hands, and looking at our time, I think we should get going. And conclude the session. This was a great session. Thank you very much to you, Andreas, Gertrude, and and Alice for participating in this session and sharing your experiences with us. It's been a very exciting session. I will now hand over to Emmy to give us a recap of key implementation conditions that have already been discussed. Thank you. Emmy or Alice?
No, it's me. 2 seconds. I'm just
okay, great.
trying to share the right set of slides. Sorry about this, everybody. For some reason, it's not coming up as one of my options. Let me just try one more time. All right, we have success. Sorry about that, everybody. Here we go.
Dear colleagues, thank you once more for joining us for the Improving the Quality of PrEP Implementation for Adolescent Girls and Young Women in Eastern and Southern Africa think tank. I think you can agree with me that we have had some hearty discussions and have generated some very important implementation considerations for future thought. I will now be providing you with a brief overview of the key areas of discussions and implementation considerations generated across our series of 5 sessions. Our first session focused on demand creation, engagement, and the participation of adolescent girls and young women. Our discussions around demand creation highlighted the fact that approaches to demand creation are dynamic and consistently evolving. It was clear that the dissemination of reliable information should occur using both digital and physical communication tools to ensure reach. Messages used in these communication tools should also be tailored to ensure that the information within them resonates with key adolescent girl and young women populations. We also highlighted the fact that peers are a trusted existing network and can be leveraged, however require the right training and support and access to tools to ensure that they maximize their potential. When it came to community sensitization, we highlighted the fact that the success of PrEP is highly dependent on uptake and adherence by adolescent girls and young women. We recognize that parents and community leaders play a critical role in healthcare decision making, and therefore it is important to educate and engage them, and this will help to reduce stigma and support long-term uptake and adherence. Finally, the participation of adolescent girls and young women. We highlighted very clearly that with access to the correct information, adolescent girls and young women are able navigators of their own health needs. They should therefore be engaged in decision-making forums, they should input on program design and implementation, and they should also be empowered to educate others and their peers to support uptake and adherence. Session 2 of the think tank focused on service delivery platforms. Some of the key messages included the fact that there is a high level of acceptability of PrEP amongst adolescent girls and young women. The barriers at an individual, community, and facility level negatively affect PrEP uptake and adherence. It was clear that a multi-pronged model which incorporates different service delivery platforms located not only in healthcare facilities, but also within the community and other non-conventional locations are required to ensure that they cater to the needs of adolescent girls and young women. Broader social mobilization of families, communities, to better understand the healthcare decision-making behaviors are needed to provide the enabling environment for PrEP use in adolescent girl and young women populations. And this can further be supported by framing PrEP as a tool for positive health and well-being, rather than by risk, which can promote stigma and discrimination. Finally, it was clear that there is an opportunity to empower community cadres of care. This includes community health workers, peers, and others based in the community to support community distribution, reduce medicalization, and increase demand creation for PrEP in adolescent girls and young women. In our third session, we focused on healthcare system considerations. We broke out into 4 groups, and each focused on a different area. The first group focused on integration with family planning and sexual reproductive health services. And this group clearly highlighted the fact that an integrated package, which incorporates a spectrum of SRH and FP services required by adolescent girls and young women, is critical. Not only is this integrated package critical, but it should also support diverse delivery platforms. This includes community-based delivery, online, e-health, and telehealth. And this is really important to ensure that we cater to the needs of adolescent girls and young women. The second group focused on what is a minimum package. They highlighted clearly that PrEP provision should be part of a broader package of services addressing the range of HIV prevention, sexual reproductive health, and family planning needs, but should also have very close links to other services, including social care. Clear information, guidance, and materials on key aspects of PrEP, including the duration, the range of protection and follow-up needed, as well as social behavioral interventions to support adherence, should also be incorporated within this minimum package. The third group focused on risk assessment, and what was highlighted very clearly here is that risk assessment should be included as part of a comprehensive approach to HIV prevention. It is also important and critical that risk assessment is not used as an exclusionary tool, and rather as a tool and a means to reach and identify those at risk. Data systems should also be strengthened to ensure improved targeting. Finally, capacity building for providers. It was important to recognize that capacity building actually extends beyond just training, and systems which support mentorship, supervision, and ongoing learning are critical for the adequate capacity building of providers. And it's also important to anticipate workforce challenges and plan and mitigate accordingly to maintain service continuity. Session 4 focused on emerging areas of interest. The first area being pregnant and breastfeeding adolescent girls and young women. We firstly highlighted the fact that PrEP should be included as a key service within an integrated SRH service delivery setting. This should include antenatal, perinatal, and postnatal care. We also recognized the potential for clinical ANC services to work together with the community to provide psychosocial support, possibly using a peer-led approach. We highlighted the need for differentiated stigma reduction messaging, differentiated by age and by population group, about the risks and benefit of PrEP use in pregnancy or lactation. This is both to reduce stigma, but also to ensure supported and continued use by adolescent girls and young women who are pregnant or breastfeeding. Finally, we recognize the low efficacy of PrEP for pregnant women who actually miss a dose. And we highlighted, therefore, the need for differentiated psychosocial support, appropriate for the age of the adolescent girl or young woman, to support continued use and ensure that not a single dose is missed. The second area of interest was innovative delivery modalities. We highlighted the fact that service provider capacity should be improved to support the provision of accurate information about PrEP, including new technologies for adolescent girls and young women. We recognize the fact that with novel biomedical methods, it's important to understand the value, needs, and preferences of adolescent girls and young women, to understand their acceptability, and also inform implementation for them. We recognize that pilot or demonstration projects may be an effective way to test new technologies for their effectiveness and community acceptability before moving to scale up and incorporating the lessons learned from these pilot and demonstration projects. Finally, at a policy level, we highlighted the fact that guidance could support countries to rapidly develop and adopt new policies and strategies. This could support swift and agile rollout of new technologies as they become available and start to change the reproductive health landscape. And today, during our fifth and final session, we focused on measuring and monitoring effective use. We heard from representatives from Zimbabwe, Malawi, and Zambia about how they are measuring and monitoring effective implementation of PrEP in adolescent girls and young women. We also heard about their challenges and lessons learned and how they are applying those here. We now call upon you to provide any final input. Based on what you have heard in the discussions throughout our sessions and the Delphi surveys you've participated in, we want to ask whether there are any final additional considerations for PrEP implementation in AGYW populations that should be explored. Are there any final comments or remarks or questions that you wish to raise at this time? Thank you, colleagues. I hope that was a helpful recap of the 5 sessions that we've been through. It's been an eventful think tank, and I hope you've enjoyed it as much as I have. So as mentioned in the slide, I think this is an opportunity just to raise any final implementation considerations or any final areas of discussion or questions. So over to you if you have any of those. Do also feel free to raise your hand or write in the chat if you have any questions or thoughts that you wish to share with the group. Just feel free to ask any questions about any of the sessions from session 1 to the current session we're in. There's no limitations. Okay. Oh, sorry.
No, it's just me. I just think that you know, we've had 5 very eventful sessions with lots of discussion, and it's clear that we have come to the end. So I think, you know, there's going to be the next slide really is about you know, what's next? What are we doing with all the information, the rich information and understanding that's been shared over the last couple of weeks and over the 5 sessions. So I think let's just go into that and then see if they're, yep. So great to hear what's next. Yes, that's fantastic. So let me quickly share the slide once more. All right. So you remember that we discussed at the very beginning what would be the outcomes in the first presentation that we had in the first session, what would be the outcomes of this whole think tank. So the idea really is to take the implementation considerations that have been generated through all the different sessions, also to bring in some of the key evidence and examples that have been shared, as well as, you know, through the discussion as well. So we've been keeping notes, and we also have a repository of some of the key evidence in AGYW and the demonstration projects that we'll also pull all together, and the outcome will be an implementation brief. And then we will also have a regional webinar to I guess to launch the brief, and with that we will bring in some of these specific best practice examples, as well as our you know, consensus on the different implementation considerations. So we will develop some implementation considerations that came from the discussion and the Jamboard and the chat for monitoring today, and we will share these all with you on a Delphi survey later on this week. Remember, we still have the Delphi survey up for session 4. So please do have a look with that. It's very quick and very easy. You just say whether you agree or whether you disagree, reject or confirm that you're happy with that implementation consideration, or you could actually add additions to it. You can also give us some other implementation considerations as well. So most of our sessions have been through this consensus building process, and now we just have the last 2 sessions that we have to finalize. We would like for many of you as possible to be part of the implementation brief. We will share it with the active members within the think tank for their review and contribution as well. And then similarly, when it comes to the regional webinar, so the regional webinar will be open to everybody. So this will be a broad audience. So our think tank has been closed to experts, but we want to take the rich sharing from here and share it further with others in the region. So that's in terms of what's next, finalizing some of our implementation considerations, and then moving forward to bringing it all together in the implementation brief and sharing it as well in the regional webinar. So we'll be in contact with you again via email for your contributions along this process. And we will, you know, obviously appreciate your ongoing engagement and support for the finalization and of these products as well. Similarly with the regional webinar, with your support with kind of disseminating and inviting other colleagues and organizations to chair as well. We were also hoping to have a research, like a prioritized research agenda, but I think maybe we had a bit too many parts and maybe a bit too optimistic about what we could all achieve in the time that we had, which isn't a bad thing. But I think when it comes to thinking about the research agenda, over the last 5 weeks, we will pull out some of those key aspects and maybe have a separate process to think that through, or just have a box within the implementation brief that, you know, draws attention to some of those rather than having kind of like a key defined list. And maybe when someone else in the audience would like to take on that prioritization exercise. So that's it in terms of next steps. Just want to check to see if there are any questions in terms of the next steps. Is that clear? Okay, great. I can't see hands, so I don't know, Mopo, I don't know if you can, or Emmy, see any hands or any questions. If not, I think the time has come to wrap up. But before I hand over to our regional advisor on HIV/AIDS at UNICEF to officially close this EPIC think tank, I just wanted to hand over to the other members of the steering, the organizing committee, to see if they had any kind of final words or reflections. Also, you at the same time, if you have any final words or reflections of the last 5 sessions over the last 3 weeks, please do add those in the chat. We would really be great to hear from you if you felt that things worked or things didn't work, what you appreciated, you know, what we could have more of next time, or maybe it was something that I guess you learned that you hadn't learned before, or an experience that you hadn't had before. But with that said, I'm just going to hand over quickly to Alex Plowright from the Global Fund. Alex, please do share with us just one reflection that you have from the think tank.
Great, thank you, Alice, and thank you very much to you for all your hard work, and Emmy, and also to all colleagues who participated so well in this think tank. It's really been an inspiring suite of discussions. I think most importantly for me, the really interesting piece that sticks out is about the potential value of the semi or partial demedicalization of PrEP, and how that could really support uptake, proper use, and continued use, etc. And looking at the question of what really is the role of communities vis-a-vis the potential of the delivery and the role of the biomedical sector in this. And then looking at that in the future in terms of how will that work as a partnership when these new technologies are introduced, particularly long-acting PrEP, which is often, you know, in an injectable form. So all of these questions and these tensions to grapple with in order to align with the expectations and preferences of adolescent girls themselves, and then to coordinate that with the challenges of how we can really provide PrEP to them within the Ministry of Health sector and involve communities. So that's something for me to take forward in my thoughts, and hopefully to work with you all in the forthcoming weeks in the development of this exciting technical brief, and see how we can then work in partnership with our stakeholders and our implementers at country level to really take this forward and to improve the PrEP programming across the region. So thank you once again, and from the Global Fund, we've really enjoyed participating in this set of sessions. Thanks.
Great, thank you, Alex. Over to you, Mopo, for your final thoughts.
Thank you, Alice, and I want to thank the team who worked actually organizing these sessions. Yourself, Alex, and Emmy. It's been quite a privilege to be part of this and to work closely with you as we have been moving these sessions forward. I think for me, what really stood out was the first session we had with young people. And not only the energy that they brought to the discussions, but the insights as well. And it became quite obvious that we actually do not involve them enough, even for a session like today. So I think we really need to be looking at how do we continually engage young people in meaningful ways, not just in demand generation, but in M&E along the continuum of PrEP provision. I think the onus is on us to see how we engage with them moving forward, as they would certainly have great insights that we would consider and take on moving forward. So I think that is one thing that I will take with me also from this session. How do we get them on board in more ways, more meaningful ways? And as having been part of this, it has been a great privilege for me. It's been great working with you, the team, and participating in these discussions. Thank you very much from WHO. Thank you. Over to you, Alice.
Wonderful. Thank you, Mopo. I'm now going to hand over to Laurie Goulet, who opened the session, so it's fit for her to close the think tank session. Laurie is our regional advisor in UNICEF Eastern Southern African Regional Office, and she is going to finish off the think tank for us. Thank you, Laurie.
Thank you so much, Alice and colleagues. I am absolutely delighted to have been in and out with you. Sadly, it was only in and out with you, but I can honestly say that in these 5 sections over the 3 weeks, it was such rich discussion. And each and every time I came in, I was so pumped and excited, not just because all the topics were necessarily happy or easy, but the level of experience and expertise and the exchange, and still at this very moment, after 5 sessions, thinking about how you can do even more and better, I find it just remarkable. The level of extraordinary expertise in this region for adolescent girls and young women is inspiring. And it comes from the dynamic young leaders, the researchers, the implementers, and especially the national governments who are leading efforts at scale. We hope and believe that through the experiences shared and the implementation considerations that you've generated and already pulled together to some extent, that these will go a long way to supporting really improved implementation and, more than that, better outcomes for adolescent girls and young women. We are very, very excited to be part of this process and to provide leadership and to work with you on the way forward on the implementation briefs and the webinar. So with that, let me say a few thank yous, and there are always many to say, and I hope I won't leave anybody out because every single person who took part in any way deserves sincere thanks. Thank you for sticking through all 5 sessions. Dear participants, we know the kind of pressures you're under now. We know what kind of difficult environment it is, and the dedicated time and brain power and emotion is just really, really appreciated. Also, the effort to learn new platforms. I personally have fallen in love with Jamboard and was really excited to see you all using it during this time. To the presenters, panelists, and facilitators, your time commitment in preparing and sharing your wealth of experience is very much appreciated. The organizing committee, what can I say? Huge thanks for your leadership, your dedicated time. Alex from Global Fund, Mopo from AFRO, and Saika from WITS. Huge appreciation for masterminding this and supporting right from the start, and for your constant insight and direction. Really appreciate it. Emmy, our bright new colleague with us, thank you for your tremendous organizational skills, for keeping us all on track, and for your dedication. Really appreciated it. Alice, always difficult for me to speak because I have the privilege of having you on my team, and your keen insight and leadership, and on top of that, your generous spirit are hugely, hugely appreciated. And lastly, to the government of Sweden, who through the Together for SRHR program has funded this effort. So I hope I didn't go on too long, but lots of thanks, and really, really excited to move this forward. Thank you.
Wonderful. Thank you so much, Laurie. And with that, if you feel like it, you can turn your video on and wave goodbye or unmute your mic or write in the chat. There's no right or wrong way but please feel free. Goodbye, everybody. Thank you for all your attention and hard work and knowledge.
Thank you, Alice. Goodbye, everyone. Thank you, everyone.
Bye.
Thank you. Bye.
Thank you, everyone.
Bye.
We're done. Yep, we're all done. Yay! No, stop it. It's my husband being annoying. Let me stop recording.